konferansa hoş geldiniz. Benim bugün
Good morning, welcome. Today I'd like to go ahead and discuss electroconvulsive therapy or ECT in pregnant women. Can we have the Turkish version of the presentation?
Tamam. Şimdi ECT tabii aslında çok uzun yıllardır kullanılan bir tedavi.
ECT has been in use for very long years, but it is a very controversial treatment also, both among physicians and the society. There was also a famous movie including scenes of ECT, and that increased the controversy. There are certain practical issues with its use, and it might be somewhat as a result of these issues, but we still know that it remains one of the most effective treatment modalities, especially when we're dealing with severe psychiatric disorders. It's one of the first options that come to mind because it gives a very rapid onset of treatment, and response rates are also very high. Therefore, we will continue probably to use ECT. So, where do we stand when it comes to pregnancy? This applies to all stages of pregnancy. Randomized controlled trials cannot be done, obviously, and what applies for medication therapy also applies for ECT. Our information comes from case series, case reports, and reviews, but we don't have data coming from any RCTs, and we end up with limited amount of data as a result. The first review about the issue came from Miller, and it actually scans the periods between 1942 to 1991. 300 case reports were brought together under this review. And he reports complications in 28 patients related to ECT, but it doesn't necessarily mean that complications are all the time related to ECT, and I'll go into that in a couple of minutes. Temporary benign fetal arrhythmias, vaginal hemorrhages, abdominal pain, and uterine contractions can happen during certain periods of pregnancy. And a very significant contribution of Miller's work is that he gives information as to potential side effects, but also goes ahead and says ECT in pregnancy, yes, there are certain risks, but as long as you take the precautions, it is relatively safe and reliable, effective as a treatment. So this is also a part of the guidelines we have. The second most important review in the field was published in 2009, I think, by Anderson and Retty. Starts from 1941 up to 2007. 339 cases are included, and in this review they observe fetal or neonatal complications in 25 cases. But lots of complications occur months after ECT, and these are very complicated processes. Of course, it's not only ECT, there's also drug exposure, other conditions that might occur. So they end up saying that only part of those complications are related to ECT, but there are 11 reported cases of death. When they look into the detail, however, they see that only one could be connected to ECT. Status epilepticus was observed in one patient pursuant to ECT, and they had a neonatal death case. Others usually came from other reasons. Motorcycle accident, for instance, was a case because they had to report everything in this kind of a review. Or another complication of pregnancy might have caused one of the deaths in this review, and they have to report that. Again, fetal side effects, bradycardia and slowing down of heart rate, peritonitis, CrossFit, etc. But these are not related to ECT that much, and I will go into the detail of these side effects in a couple of minutes' time. This is a review from our country, from my hospital, in fact. Ömer and Nesrin made this review, and they had a look at side effects and the potential causes of these side effects. They end up with the same sort of conclusion. So they end up saying ECT can be used in psychiatric disorders. It's an effective and relatively safe treatment, they say. There's another review from 2015 this time around. The numbers are lower compared to others. You can ask why that's the case. They had somewhat stricter criteria, so they had to exclude certain cases where they did not have complete data, and the number they have is 169. Now, the average session of ECT treatment is 10 sessions, and the most frequent complication, and of course, since these are case reports, bringing them together is somewhat difficult, but in about 60%, they end up with depression. They are depression and bipolar disorder cases in the second trimester, about 52% of them, 10 to 15% first trimester, and then the third trimester, about 1/3 of the cases in this review. The most frequent complication for mothers is premature birth, early uterine contractions, and for the fetus, reduced fetal heart rate. So, what do the international guides on ECT say? They don't have anything as far as contraindications go. When I was a student, during those years, in my university, in other hospitals where we were trained, I actually know for a fact that it was relatively frequently used in pregnancy. But these figures seem to be on the decrease. Maybe the new laws that are being passed, or the attitude of people can play a role in that, and there's also stigmatization attached to this kind of treatment. But all of the guides say the same thing about one point. They say that it's an effective treatment, that it's a reliable treatment. But we don't really have that much detailed information in guidelines. We know that major depression in pregnancy can reach a prevalence of 12%, and some of them can be really severe, requiring urgent treatment. We don't, unfortunately, have exact percentages and numbers of pregnant women on whom ECT was applied, but throughout the years there's been a decline in ECT practices and the number of cases, so we might end up with the idea that it's actually underused as a treatment modality. So, what should we compare ECT to in pregnant women? Of course, pharmacological treatment and their risks, or not treating. These can all be options for us. But if we are to talk about ECT, we're probably dealing with a moderate to severe case or range of diseases and conditions in pharmacological treatment. And this might give you a misconception, but you have malformation risk, prematurity, fetal growth, stunting, and long-term effects on children, of course, are not that well known, the effect of pharmacological agents, and bringing all these together maybe is not the best thing to do, because on the one hand you have certain pharmacological agents which are reliable in use for many years, but you also have those which are relatively new and about which we don't necessarily know as much. But if we are to compare ECT to other treatments, then pharmacological treatments should also be one category, and they also have side effects. And there are also psychiatric conditions which go untreated. When people apply to us, and in the professional circumstances, of course, there are always concerns as to treatment, at least initially. But with recent publications in the literature, the worst-case scenario seems to be going untreated. It has now become abundantly clear, because It brings along a reduction in self-care, poor nutrition, increased risk of substance abuse, very poor antenatal care, and again, low birth weight is an issue in pregnant women who do not receive any treatment, or stunting in growth, hypertension, and preeclampsia. Risks also tend to go up, and what's maybe most important is that there's an increased rate of postpartum depression. For the baby, there's a risk of preterm birth, low birth weight, reduced head circumference, the connection between the baby and the mother being disrupted severely, and the children can also be more prone to anxiety, depression, and other psychiatric disorders as years go by. Now let's have a look at this slide. It seems as if the treatment-related risks are actually very reduced, but maybe that's not necessarily the case. But what I would like to underline is that the risks of no treatment are also very, very significant, and maybe they outweigh the risks of treatment. Now, since I work at a maternity ward, patients and relatives and family, they always tend to focus on pharmacological treatment, on medication and their side effects. But let us start with simpler things. Smoking, right? No one really thinks about that. But smoking has really, really bad side effects compared to treatment. No benefit whatsoever. So, I mean, risks cannot be brought down to zero for anyone, but they're not maybe as high as they think. 3 or 4 may go up to 5 in terms of percentages, but it's not really high for many people. So what are the indications? These indications are very familiar for us. ECT indications for pregnancy are not that much different. But most frequently, what do we have? Well, we have unipolar or bipolar depression. One point that needs further highlighting is that it's not only for major severe depression. Moderate depression can also be a condition in which you have ECT as an option, and it should also, of course, be treated, pharmacological or ECT. But maybe in lesser cases of depression, other methods can be considered. But when it comes to the risks, we have suicide, homicide, infanticide. Moderate cases of depression are no joke either. They need the same attention. We're not, of course, focusing on postpartum psychosis, but there's also striking information about that. In a 1999 study, psychotic cases were compared, postpartum and not postpartum cases. In postpartum psychosis, ECT achieves much quicker response according to the study. So when should it take the center stage, ECT? If there is insufficient response to medication, and of course the condition, the psychiatric conditions, suicide, infanticide, homicide, risk of the patient, they need to be evaluated, or poor nutrition, poor uptake, poor oral uptake, and pursuing nutritional situations, if they require rapid response, then of course ECT is clearly the first option for us. Let's have a look at the response rates. These are for pregnant women. In depression, including partial response, the response rate is 84% or so. In schizophrenia, it is similar to general ECT rates, and it is somewhat lessened, somewhat reduced down to 61%, and the rates are similar to non-pregnant individuals. But compared to psychotropics, of course, the response is much quicker. Potential side effects of ECT. When you bring together all case reports, it seems to be around 10%. Potential risks, of course, should be part of the decision-making process. The patient selection is equally important. And the reason is that maybe you also experience this in your own practice, not just for pregnant women, but in the general patient population as well. Sometimes patients already do know what is actually helping them, and you can end up with patients, a group of them, who say that ECT really does benefit me. So, of course, let's evaluate the potential risks, but we should also maybe listen to the patient and the friends and family of the patient, of course, including the physician. So let us make this decision all together. Okay, so let's have a look at side effects. Of course, there are certain seizure and electrical stimulation related risks. The most frequent, as far as maternal side effect goes, about 3.5% prevalence, is premature contractions and premature birth. And the hypothesis at this point is that as a result of contraction during seizure, oxytocin actually goes up, their levels go up, and this might have an effect according to the theory, because this electrical impulse doesn't really necessarily transfer to the baby over the uterus. There might be other factors, dehydration, infection, or hypoxia can also be playing a role in these contractions. So what can be done? Well, especially maybe starting from the third trimester, tocolytic treatments can be considered. Tritodrin, for instance, is used, but of course we need separate assessment, individual assessment for each individual patient, it's clear, and this doesn't apply to all patients, this treatment. Other risks related to potential seizures. Now, rather than the electrical current, it actually the riskier, actually, the physical injuries and the hypoxia that develops as a result or in the process is also important. So, during the ECT, there are certain measures that can be taken, some precautions, and this is already some of the stuff that we're doing routinely, but in pregnant patients we have to pay better attention. We can use pulse oximetry and achieve pre-oxygenation and maintenance, sufficient muscular relaxation to prevent any trauma from happening. Another very important point which can result in hypoxia is prolonged seizures, so we need to prevent these. So we need to keep them lower than, or shorter rather than 120 seconds, and this gives us an idea as to the dosage of some of the agents that we might be using. Okay, we have the patients have a seizure. If it doesn't stop, if it turns into status epilepticus, what does happen? Now, this is a first in case reports, and unfortunately it has a deplorable ending, but there are lots of factors. This is a 31-year-old patient, bipolar patient. It's the first pregnancy at 22 weeks. You have 3 more minutes. Okay, let me speed up then. High-dose benzodiazepine was applied and fetus was lost in this particular case. So what are some other risks? Placental separation can happen in these patients. Vasoconstriction can happen. And if there are fluctuations in blood pressure, then of course this increases the risks, but not so high. When it comes to neonatal mortality, what awaits us? We talked about status epilepticus, and in a publication in 2007, multiple interhemispheric cerebral infarcts were reported. Miscarriage rate seems to be 1.6% or so, and this shows that ECT doesn't necessarily increase that risk that much. Other side effects? No cardiac events have been reported. There was one case with cerebral hemorrhage and preeclampsia and certain abdominal pain which cannot be explained. These are also ECT-related side effects, but there is no specific increase in relation to pregnant women. There are certain anesthesia-related risks as well, because during pregnancy there is an increase in progesterone and lower esophageal pressure goes up. As a result, pulmonary aspiration risk is increased, and aortocaval pressure is also increased as a result of the enlarged uterus, and placental perfusion can be degraded or disrupted. So fetal hypoxia is something we need to be aware of. But these physiological changes are not that much required before weeks 14 to 16, so no modifications are required. Anesthesia-related side effects, fetal arrhythmias, 22%. These are usually temporary and secondary to fetal hypoxia. As I was saying, oxygenation needs to be ensured really well, and we should have high output, at least 3 minutes, and it can be preventable. But we should also pay attention to preventing hyperventilation, because that also has negative effects on the baby. Aspiration pneumonia, I already made that point. Certain physiological changes due to pregnancy mean that its risk is actually increased, so if necessary prior to ECT, anti-acid prophylactic approaches can be applied. We also sometimes give anticholinergics to women in preventing bradycardia and increased pharyngeal secretion. There are certain studies about this. Certain have reported increase in malformation with atropine. Some did not. So we might be cautious as to when it comes to using anticholinergics, maybe not use them unless we really have to. When it comes to other anesthetic agents, the dosages should be kept close to minimal if possible, and if really necessary we should use short-acting narcotics. Propofol is used a lot, and it's used a lot in C-sections. That's where our information comes from. Anesthetic agents between pregnants and non-pregnants don't seem to differ that much. For propofol, we have to pay attention to bradycardia and hypotension. If it starts acting really early on, it can create a problem in the pregnant women. Fetal cardiovascular complications if they accompany. Thiopental is also used in Turkey. Metoxetyl is not available in Turkey as far as I know. So as I was saying, some people have switched from propofol to thiopental, and there is also another agent, sevoflurane. It has tocolytic effect, and if uterine contractions are really high, it can be recommended, but it has really severe side effects as far as anesthetics go, so it's not that much preferred. When it comes to muscle relaxing agents, what we need to know is that after week 30, pseudocolin levels go down, so seizures can be prolonged, and the agents which create neuromuscular blocking can have a longer effect. So we can use rocuronium and succinylcholine very frequently in our hospital. Our information as to succinylcholine is more ample because it's used more. It's used more in the first trimester, and not much has been reported when that's the case, but if it is in the third trimester, fetal respiratory depression and low UPGAR scores were achieved in some cases. So in third trimester, closer to birth, maybe succinylcholine should be weaned, and maybe we should consider other options. I talked about this article about pressure. This is not only applicable for ECT, generally speaking, in pregnant women starting from week 20. The right side of the hip might be elevated slightly, so we can achieve a tilt position, and this also applies to prior to ECT, and until the patient is normal transfer, this position should be maintained. But this position applies for other pregnant women with other procedures. Sufficient liquid intake is also something that we need to be careful about. Other things that have been reported: severe pre-incompetence, preeclampsia, vaginal hemorrhage. No significant problems in 5, but 1 resulted in spontaneous abortus. So ECT during pregnancy, does it have long-term effects on children? As you see, the latest publication about this issue is from 1964, and the numbers are not sufficient. Some did not report any major problem. The last one from 1964, 2 cases were reported to have mental deficit, but not that well explained. But we have to pay attention again to the third and second trimesters. The ECT was applied in these trimesters in these cases. So what do we need to do before the ECT? A thorough and collaborative assessment is required, and the indication needs to be very clear, and that information needs to be shared with the patient and the relatives and family of the patient, and everything has to be properly documented for legal purposes. Everything we do, we need to write down, basically. This is not something that we can, of course, take care of alone. We need specialists of anesthetics, gynecology and obstetrics. And what we want to achieve is, of course, to have something having an effect really quickly, but no side effects. Benzodiazepines, anticonvulsants, these need to be maybe taking the second stage in terms of treatment. Do we need additional other treatment or not? Should we use pharmacological agents or not? Again, it should be a team decision. There are also other publications without any medication, but some say that if the targeted symptoms actually are gone, then you can stop the medication. Of course, it needs a team decision as well. During ECT, I've already covered the points that we need to pay attention to about anesthetics, for instance. Now, bilateral ECT can sometimes be required. In unilateral, if you do not have sufficient support, sufficient response, then it can be chosen, and you need close monitoring for risks. After ECT is terminated, follow-up is also important to using ultrasound or Doppler, because if you are aware of the complications early on, then that's the best thing, and if necessary, ECT should be stopped. I've already covered these points. For anesthesia purposes, prevention of hypoxia is very important, and low dosages should be used. Muscle relaxation should be effective. Vital signs should be, again, monitored and followed. For obstetrics, first we need a basal assessment and evaluation. If we have a pregnant woman in our service, in our ward, for instance, we have an obstetrician evaluate the lady so that we know what we're faced against, so that we can take the advantage over potential things that might happen with ECT. Now, in our hospital, this is not really very possible, but we may sometimes have an obstetrician during ECT. Other things such as liquids, positioning, etc., we need to be careful about these. And when it comes to psychiatric purposes, ECT dosage, again, should target prolonged seizures. Bilateral ECT is important. Regular psychiatric examination of the patient should be done for assessment purposes. And if the symptoms are gone, and if the risks are high, we can terminate the ECT treatment, or we can do maintenance therapy. This is the end of my presentation. Thank you.
Teşekkür ederiz.